Thank you, Shlomo. Thank you for your friendship and thank you for having me here. It's a privilege to talk to the Israeli Sinological Society, and I would like to apologize for not being able to continue with your beautiful language. After all, it's my first visit to Israel. Maybe next time I can do better. Breast cancer in older women is a topic that I like discussing quite a lot because I think that if we can improve, if we can make a change, only a minute change, given the proportion, the huge proportion of breast cancer that we are seeing, I think we can impact on the global survival. And as you can see here, the older we get, the more the prevalence of breast cancer. Breast cancer, as was rightly said yesterday, has got two important variables. You need to be woman and you need to be old to get breast cancer. So this is more statistics that shows how rare breast cancer is among the younger population. So we've all been fooled by the Kylie Minogue, at least we were in the UK, Kylie Minogue effect, where the number of referrals to the breast unit doubled countrywide. The number of mammograms also doubled, and there was no increase of breast cancer detected. On the other hand, breast cancer is a disease of older women. They don't know. I'm not sure why. They are not aware. But I think this is crucial. It's our responsibility to bring this up to the attention of the media, of the politicians, and make sure that they appreciate what the trend and the age distribution for these diseases. They are not aware, and it's proven that this is a lovely piece of literature from King's in London, Amalia Ramirez, and they prove that if you inform older women in great detail, with leaflets, with discussion, these information stick to their mind and they get convinced. Otherwise, they don't seem to be sufficiently informed and realize. This slide I presented yesterday, and it shows how with the progression of our patient's age, the cancer-related survival drops. In pink is Manchester, in blue is the UK as a country. And this survival is kind of similar to other European countries, so it's not just that in the UK we do bad, which is definitely the case, worse than others, but across Europe we are also doing quite bad. And it is true that until the 80s, breast surgery was considered the standard treatment for breast cancer, but it's also true that particularly in the UK, a group of Scottish surgeons, I can't believe it was a surgeon self-inflicting pain, that we ended up promoting the use of primary endocrine treatment as the magic tablet, the use of tamoxifen, which is very well tolerated and definitely showing extraordinarily good response, but the bottom line is that above the age of 70, 42% in the UK would get hormonal treatment as the sole treatment option, and beyond age of 80, 55% surgeons, means more than 1 in 2, would treat these ladies with hormonal treatment. So this is indeed a British problem, where we have more and more patients in their 70s and 80s not receiving surgery, more and more patients receiving hormonal treatment, and less patients getting radio, less patients getting chemotherapy as a whole. Things are slightly changing, so that with the latest BCCOM data that have just been published, the trend between 2002 and 2004 is improving. We had 41% non-surgically treated patients overall, and now things are shifting. We have been putting lots of pressure, and you can see nationwide that some units are still very much non-surgically oriented, whilst others are more keen to consider surgery as the option. This is kind of surprising because we have data now, and I'm sure you're aware of this lovely Cochrane overview, where Malcolm Reed's Linda Wild and colleagues from Sheffield prove that yes, there is no significant survival gain in giving surgery versus hormonal treatment, but there is a huge difference in terms of local control. Patients do much better in terms of quality of life and local control of the disease. British problem, but not just. Dutch data showing that surgery, the radiotherapy, lymph node dissection, and adjuvant treatments are less administered in the elderly group, whilst hormonal treatment is more frequent. And once again, Dutch survival curves. This is one of the original beautiful paper from Switzerland, where it was shown that half patients, elderly patients with breast cancer, were undertreated, and these strongly decreased their specific survival. You can see in the curves that best standard treatment, despite the age, achieves the best outcomes. The poorest the treatment, the hormonal treatment or non-surgical treatment drops in poor results. American data, because it appears that the same data are actually putting the US ahead of us, and still I'm puzzled by series like this one by Cynthia Owusu, where she confirms that in the data that she collected, the older subsetting is also poorly served. So when I came to the UK, I was asking myself, why is that? What's happening? Let's go and let's see what people does on the battlefield. I asked, we want to assess for frailty. Frailty is very important. And I ran this survey, and in this survey I sent out 350 questionnaires, 43% compliance, thank you very much. It looked like that most surgeons were aware of the burden of the problem in the elderly. They did not respect anagraphical age as relevant for the treatment planning. They wouldn't admit denying breast surgery solely only on the basis of the age. They would privilege the quality of life and quality adjusted survival. They admit the chance of discussing with geriatrician, but they use no geriatric assessment tool and no risk assessment tools at all. And this is where my interest started in the assessment tools. We do not have the perfect tool, I'm sorry to say, and this is why a decade ago we started with the search of the Holy Grail, that everybody was looking on how best to define frailty, and which are the patients that we need to bring to theater and which are the ones that we do not want to touch at all, and give them the tamoxifen or the aromatase inhibitors. So one way to define this patient is simply with the rule of thumb. Or somebody might use life expectancy tables that we derive from insurance companies. The number or the severity of comorbidities is an interesting one. Of course, our anesthetists are aware with the ASA, and in the UK, POSSUM is kind of popular. And more recently, we have learned a lot from geriatricians, so we have learned geriatric assessment tools and screening tools. Just want to spend a second on the rule of thumb, because we shouldn't feel guilty for what we are doing. This lovely paper by Kare Christensen, in this experiment, he showed these kind of pictures, twin sisters, and he asked 3 different groups which one was the most frail, which one would die first, which one would not tolerate treatment. And these 3 groups were A, a group of elderly ladies, B, a group of geriatric nurses, and C, as a random control, he took young lads out of the university from the business academy, in the assumption that they would know nothing. Now, surprise, surprise, the 3 groups did perform very well. They show that they were very effective in predicting short-term mortality. So we are kind of capable to say, hey, you are fit or you are not fit. So this is not to be, we don't need to blame ourselves for our rule of thumb skills. The problem is that it is not reproducible. My esteem might not be entirely superimposable with my colleagues, so there is a lack of consistency. This is why this is useful in our clinical practice, but probably not enough. And that's why we developed an experience that we call PACE, Preoperative Assessment of Cancer in the Elderly, that was published some years ago. And this experience showed that fatigue can be easily collected with a short questionnaire, and fatigue doubles the risk of complication, hospital complication. Instrumental activities of daily living also affects post-operative complication, and ADL, activities of daily living, impacts on the length of hospital stay. Not only, but when none of the components, these tools are deranged, there is a 15–20% risk of post-operative morbidity. When one is deranged, the risk goes up, and you see how prevalent the risk can be when more than one tools are deranged. So this we found very interesting, and we want to now, because this is a cumbersome and time-consuming exercise, we want to compare all these instruments that we found useful in predicting the post-operative outcome versus 3 more quick, easily administered, patient-friendly assessment tools, the VES-13, the Chronicle Frailty Index. This is 13 or 15-item questionnaires that you hand to your patients when they are waiting in the waiting room, so that they can come to you with a score, and you can easily see whether these patients are deemed fit for a surgical procedure, and or you better be careful and probably avoid being aggressive. So the endpoints of this study, which is still ongoing, we are planning to complete accrual over the next months, and we are looking for 30-day mortality and morbidity. There is a trend toward the media and toward the charities as well to consider, to focus, to switch the attention from the younger cohorts to older patients, as you can see from leaflets. Pharma companies also have taken the message on board. There might be a little bit of photoshopping here. Some wrinkles might have disappeared, but the message is that elderly patients are also considered. From the battlefield, I would like to spend a few words on practical issues. Breast sparing or mastectomy. We have several options, and I think we have the same option that we have in the younger cohort. Friends in Greece, where I visited recently, they tell me that Greece has 2,000 islands. So they sometimes consider geographical mastectomy on the ground that it is impossible for this 85-year-old lady to relocate in Athens or to move daily with a 4 hours trip on the ferry up and down. So we need to tailor treatment according to the individual's request and preference. But please be aware that the patient's requests are still there, and I do have patients in their 80s who come to me and say, I go swimming, I love dancing, I got a new boyfriend, I would like you to do a good job for me. And I think it's our responsibility to respect their will. So don't take it for granted that they do not deserve cosmetic surgery. I've had patients in their late 70s asking for reconstruction. And in fact, there is some literature going around on reconstruction, breast reconstruction in the older group. The axillary dissection, maybe there is no hard data proving the advantage of giving the axillary dissection in the elderly. We have been actually saved by the advent of sentinel node, which is less aggressive. On the other hand, not all centers have frozen section perioperatively. We don't actually in the UK. Most units don't have it. So you ask yourself if this cancer is a grade 3, it's in the upper outer quadrants, it's a T2, 2.5 centimeter. Do you really want to go for sentinel node? Would it not be easier to go for a low axillary sampling to avoid a second operation on a patient that you are kind of reluctant to operate even in the first place? So debatable, but please focus on the patient's will. I personally use no drain at all in my breast practice, even if I go for axillary dissection and mastectomy, and I definitely advise you, considering early discharge, breast surgery should be dealt, in my mind, like a day case procedure. General anesthetics, you can do mastectomy under local anesthetics easily. The use of blocks is extremely helpful. You need a good anesthetist, but if they are on board, it's a lovely teamwork. And the final one is radiotherapy. Is it really needed? Again, no hard data. Definitely no hard data for radiotherapy as an adjuvant for DCIS in the conflicting data. So I'm not giving you answers, but I'm posing the question to you. This is where we should be looking into. The patients, the extent of the procedure should thus be focused on the patient's preference. Communication, because communication is another one. Sometimes they tell me, my breast nurses tell me, but why do you push for surgery? She doesn't want it. Hang on a second, nobody wants surgery. Not that I've never seen a patient who comes to you, oh yes, bring me to let's have a mastectomy. Nobody really wants it. It's a disgraceful procedure. But you need to tell them that it is an easy one, that it's pain-free, that she can go home the same day, that the complication is all right, complication is unlikely, and she will be doing very well. If you sell it like that, the patient preference might swap, and the communication is also to be taken on board. I've expanded those thoughts in a recent booklet of mine, and the key points that I'm leaving you is enhancing patient's awareness, understanding the patient's needs, improving surgical standards, delivering a treatment which is tailored to the patient, patient-centered and focused, and promoting research. And I thank you for your attention.